have data, but it's not very good, and I'll tell you why as we go on. But the short story is that for depression in general, we know some things about epidemiology for the whole kind of population, mostly done in people without medical illness. What we know about depression in people with medical illness is a lot worse data, very spotty. And what we know about people with cancer and depression in terms of statistics is worse yet. And what we know about people with renal cell cancer and depression, you can imagine. So that's where we are in terms of the facts. Okay, so the first thing I want to say is sort of what is depression? And depression, the way that I'd like to think about it with you today, is different from sadness and grief. Pretty much everybody who gets a diagnosis with cancer and then lives with it has sadness and grief and a lot of anxiety as well. But depression is really a continuous state of mental anguish. And it's characterized by relentless low mood and lack of enjoyment, and hopelessness, helplessness, and worthlessness. Now I said both continuous and relentless. I can't emphasize that enough. So this is William Styron, who is a writer, and he was depressed for a good part of his life. And what he said about depression in his book, Darkness Visible, was this: despair comes to resemble the diabolical discomfort of being imprisoned in a fiercely overheated room. And because no breeze stirs this cauldron, because there is no escape from the smothering confinement, it is entirely natural that the victim begins to think relentlessly of oblivion. So when this is your state every day, do not pass go, come directly to see me. Other forms of sadness, though, that happen in this sort of context of cancer are adjustment disorders. And this is intense sadness or anxiety that comes and goes. So it hits you multiple times a day, often in the middle of the night, you're sort of grinding on things. But these feelings over time become more manageable. They don't really go away, but you feel like they're not so intrusive in your life. The feelings are also responsive to distractions and to sort of the influence of family and friends, to spirituality and faith, to good news about treatment. When people are depressed, often even if they get good news about treatment, they don't feel it as good news. And pursuit of favorite activities can distract you from the feelings. The treatments for adjustment disorders, which are common, may include group or individual psychotherapy, yoga and exercise, and or medication. But medication, for reasons that we'll get to, we try not to use with the adjustment disorders, except for anxiety. So another type of sadness is grief. C.S. Lewis said in his book, A Grief Observed, that he was surprised to find that grief felt so much like fear. So grief comes with both sadness and a lot of anxiety. It's characterized by intrusive thoughts about what you've lost. So in this situation, thoughts about sort of being on the other side of that fence once you get the diagnosis of cancer and not being able to get back over the fence.
Excuse me, Dr. Rosenblatt.
Sure.
Could you put the microphone on your left collar?
Sure.
Because it just goes up and down.
What's going on?
Yeah, every time you look at the screen, it goes down.
My husband says I'm the enemy of technology. I feel it's mine. And so with grief, then, you have yearning for what is lost. You have a feeling of kind of purposelessness and rudderlessness. There's an emotional numbing that can happen, where if somebody like me says to you, well, you know, what's going on? What are you feeling? You have no idea. You just feel bad. There's a shattered worldview where all your expectations are turned on their head and your trust in life is gone. There can be irritability, bitterness, and anger that comes and goes, and a feeling of sort of that it's difficult to see your way forward. Now, interestingly, you can see that this seems like a list that's pretty depressing. But grief, like adjustment reactions, sort of fluctuates in terms of the symptoms, and it can come on as almost like an ambush during the day. You're going about your business, and then all of a sudden it hits you from behind. Also, the symptoms get milder over weeks, months, and even years. But they really do get a lot milder. So when I say years, it's not a sentence to misery. And if they don't, it's depression. So some things to think about, just in terms of the bad statistics that we have, are during treatment, about 25% of people with cancer have symptoms of major big D depression. And that's this list that includes, you know, sadness for most of the day that goes on for more than a month. Anhedonia, which is lack of interest and pleasure in your usual activities that would bring those things. And the hopelessness, helplessness, and worthlessness. So 25% of people with cancer at some point in their illness do have major depression. And in the general population, that's about 17%. The diagnosis of depression increases with advanced disease, physical debilitation, and pain. Pain is a huge confounder. Untreated pain can mimic depression by putting on a kind of oppression in terms of your daily and weekly and monthly and minute suffering. Anxiety disorders occur in approximately 12% of people with cancer, and we're not talking about adjustment issues, we're talking about full-on anxiety disorders. In the general population, that's about 6%. And then depression mixed with anxiety, which is a very common presentation of major depression, where you will have the low mood and the sadness and the lack of interest, but you also have panic attacks in the middle of the night or in the morning. That occurs in about 12% of people with cancer. Adjustment reactions, which usually are a mixture of anxiety and depression or one following the other, occur in 80% of people with cancer. And I would maintain that the only reason it's not 100% is because they caught some of the people who were in that I'm managing it mode at the moment. So how good is our data in psychiatry? Well, we don't really have any clear incidence and prevalence data for depression and anxiety in people with cancer, certainly. Part of the problem with the research in psychiatry is that the studies, some of which do have big populations, use different definitions of depression and anxiety. So some of the definitions brought in people with some of these adjustment reactions with what we call dysthymia, which is a more chronic state of not terrible sadness, but a kind of grayness. And those people, as it turns out, do not respond to medications very well. And so we'll get to that in a minute, but that's a real confounding issue in our research. Lab research on receptors can kind of lead us astray into thinking that we have more clinically applicable information than we actually have. That being said, we cannot measure your receptors. We have no blood tests to let us know anything about that. And a friend of mine who's a biochemist who works on brain receptors said to me that basically where we are right now is we know about 5 notes, and we don't even know if all those notes belong in the same chord of the symphony. So that's where we are in psychiatry. It's much trial and error pretty much with meds. A lot of the data comes from case reports, non-randomized trials. A lot of them are not double-blinded. There's some recent work with placebos, which we'll get to too. So depression, as David was just saying, magnifies pain and other physical symptoms. It disrupts relationships because you become withdrawn and irritable and sad. And often family members and friends will become very distressed. And they begin to hover, which is incredibly irritating. And so it does really get in the way. It can lead to a desire to hasten death, which seems a little unusual to talk about in this group, and unusual to talk about in people who have often been through multiple treatments and multiple uncomfortable treatments, but it happens when depression comes in. It may lead to discontinuation of potentially helpful treatments, and there is some research on this. A study was done with some people who were over the age of 60 who had cancer, and they were asked about decision making. They were asked to make decisions about what they would like for their care, and what they would like in terms of code status and things like that. While they were depressed, they were treated for the depression, and they were asked these questions again, and it turned out, as you would expect, that they wanted and felt they could bear much more when they were not depressed. And so they would have chosen treatment over no treatment. Depression also interferes with eating, drinking enough to tolerate treatment, and the management of central lines, G-tubes, and other things. It interferes with physical rehabilitation, so when you're in a state where you can actually get stronger, either between treatments or after treatments, you don't get as strong as you could. And with the management of chemotherapy side effects, or other treatment side effects. As it turns out, it's easy to diagnose depression. The simple question, are you depressed, was found in a study by Chochinov, now about a decade and a half ago. And what that did is that was very reliable to pick up people who were depressed. He compared it head-to-head to the HAD, which is the Hospital Anxiety and Depression Inventory, which is used a lot with people with medical illnesses, and to the full psychiatric interview, which is sort of the gold standard, and found that this question was as good as either of those at predicting who was actually depressed. And if the answer is yes, the next most important question is, are you enjoying things that you usually enjoy? Because if you are not, that is 100% that you're depressed. And then other things like worthlessness. So are you convinced